Let's continue with the next presentation. I'd like to invite Professor Michael Haude. It's really a great pleasure for us to have you here. He's going to discuss about DAPT in ACS patients.
So, Mr. Chairman, ladies and gentlemen, it's also a great pleasure for me to be here and to share some thoughts on the aspect of DAPT and the use of the right stent in a particular setting of acute coronary syndrome. So if we really look at what the ESC has established this year with the focused update on dual antiplatelet therapy, they really focused on all the randomized trials that are available. And if you look at the image here, you can see that over the last years, most of them looking for a longer duration of DAPT. But there were made clear recommendations on what to do, and I would like to focus first of all on the acute coronary syndrome patient, and they didn't separate whether these patients are going to get a drug-eluting stent, a bare metal stent, or a drug-coated balloon. But if there is high bleeding risk, the issue is, if that is not the case, the patient should go for DAPT 12 months. But if there is high bleeding risk, a shortened duration is recommended, trying to catch up about 6 months in favor of aspirin and clopidogrel, or aspirin and ticlopidogrel. But there is no given any kind of advice whether there are special stents that should be preferred in that setting, yes or no. And this thing even becomes more complex if this patient is going to require additional anticoagulation, for example, because it's an atrial fibrillation patient. You can see the recommendation here, very complex, very individualized, but again, there was no strong recommendation whether we do have certain kind of drug-eluting stents which are maybe more attractive in that particular setting versus other ones. And there I would like to step in and report a little bit on what has been distributed later on this year during the TCT conference some weeks ago for this combo dual therapy stent, which is a stent which is not brand new on the field. We do have it for some years here in Europe, CE marked and available. A stent that has two features. One is the antiproliferative scenario with an abluminal sirolimus release from a bioresorbable polymer. And then on top of that, there is an ultra-immobilized anti-CD34 antibody coating which attracts circulating progenitor cells. And we know that during acute coronary syndrome phases, there is a super burst, especially during STEMI, of these progenitor cells. And now if they flow along the stented segment, they can attach to the antibody and create a faster, more frequent and well cellular coverage. And that is the attraction of that particular device. So it has been now tested, and I think this is very worthwhile in a particular setting of acute coronary syndrome patients in this randomized trial enrolling about 1,500 patients with acute coronary syndrome, almost half of them presenting with STEMI, who had a successful implantation of that device and then were treated for only 3 months of DAPT, which is fully against what the guidelines so far has recommended to us, versus the recommendation of 1 year. And I would just share with you the results, and you can see for the primary endpoint, the combined endpoint of cardiovascular death, reinfarction, and revascularization. You can see that there is no significant difference over time between the 3 months and the 1 year period of DAPT, and that this is quite remarkable. So the question is now, is probably when we stop the 3 months DAPT in this stent, is there a late catch-up of events, thrombotic events over time? And therefore, this pre-specified landmark analysis was done, where you can nicely see that these curves are still following each other with no significant separation. So there is no really late catch-up. And this trial really is questioning the first time whether we really need, in acute coronary syndrome patients, a duration of 12 months DAPT. When you look at these single secondary endpoints, all these clinical endpoints here, there was not a single one that showed significant difference in favor for the 3 months or the 12 months scenario. So very important to mention. Also, no late thrombotic events with respect to stent thrombosis. In general, one has to appreciate that the overall event rates in the trial for this cohort of patients with acute coronary syndrome, and almost 50% presenting with STEMI, were quite low. So in summary, this is the first study that is restricted to ACS patients with a shortened DAPT for 3 months, showing to be non-inferior to a 12 months DAPT when you use this particular combo dual therapy stent. These findings that were shown here in the reduced trial were consistent for all pre-specified subgroups, and therefore a shorter DAPT strategy can be considered, especially in those patients where are prone to bleeding complications. Nevertheless, the whole story needs to be supported by further randomized trials, also including drug-eluting stents. And if you want to know whether this particular combo stent is comparable with safety and efficacy to drug-eluting stents, at the same conference, the Harmony trial results were presented with clinical endpoint data for 1-year target vessel failure, and you can see there was non-inferiority between the combo stent and the comparator, the everolimus-eluting drug-eluting stent, the Xience. And there is one particular point when we looked at the angiographic data which supports this endothelial coverage, because when you look at the instant late lumen loss, this in particular was somewhat non-significantly larger, showing that there was some cellular uptake there, which was not in the case for in-segment late lumen loss. Nevertheless, this didn't translate into any difference with respect to restenosis, neither in-stent nor in-segment. But what is the reason why this endothelial cell capturing is so positive, or could be so positive? There was coming from the Harmony trial with a subgroup of patients who received OCT control over time. The very valuable data supporting that was already presented from the ECO combo trial, that with the combo trial we have first of all more cellular coverage, and when we look at the quality by OCT, it is also more mature and firm, what we do see here in comparison to the Xience. And you can bring that into numbers, and that shows you that the cellular strut coverage is significantly better with the combo at the certain time frame at 1 year. And when we look at the more mature scenario, we see that we have a more homogeneous neointimal cellular coverage documented by OCT. So, in conclusion, for the last 20 seconds, I think with this particular device, the combo dual therapy stent, it provides us good safety and efficacy profile in multiple patient and lesion subsets documented in the trials. For the first time, we have a device that has shown in ACS patients that outcome with only 3 months of DAPT is comparable to a 12-month of time, and therefore this device can be considered as a first-choice stent device for patients with acute coronary syndrome and being prone to high bleeding risk. Thank you very much for your kind attention. Gracias.